thank you for joining us. We've got folks registered from all over the US tonight and even in the UK. So I appreciate all of the thoughtful questions that have already come in. And thank you for the time that you're giving to participate today. We're here to talk about MS with Dr. Robert Gross. I'm Kelsey Morrow, Education Manager at the Rocky Mountain MS Center. I would like to thank the pharmaceutical companies who have provided patient education grants to support this series. Thank you to Bristol Myers Squibb, Genentech, and Janssen Pharmaceuticals. We will post a link for our evaluation in the chat. Please do take a moment to fill that out after the event. It helps us improve this series and all of our other educational programming. This speaker series is just one piece of our education programming. We have a variety of formats available to you, including both in-person and online options for most of our programs. And then we also have a lot available on demand through our YouTube channel. Coming up, we've got a webinar on October 9th, which is next Monday, for how to prepare for your neurology appointments. So if you've got questions about what to bring, what to keep, how to prepare, that's a great place to ask those questions. Our Fall Education Summit will be a hybrid event on November 4th, so you can attend that in person on the Anschutz campus or watch it online on Zoom. And then before the end of the year, we've got a couple more conversations on MS events, as well as webinars on neuropsychology, MRIs, SSDI, and fatigue. So if any of those are interesting to you, we do announce all of our educational opportunities through our mailing list, our Facebook page, and you can sign up for notifications through Eventbrite. And now I'd like to introduce you to Dr. Robert Gross. Dr. Gross attended college at Columbia University and medical school at NYU School of Medicine. He completed an internship in internal medicine and residency in adult neurology at Brown University in Providence. He then returned to New York to complete a fellowship in MS neuroimmunology at the CGD Center for MS at Mount Sinai Hospital. Dr. Gross sees patients with MS and related disorders of the central nervous system. He divides his time between patient care, teaching, and clinical research. We've had a lot of great questions submitted already at registration. We'll get to as many of them as we can. And you can ask, again, new questions by typing them in the chat box. Today's presentation is for informational purposes only. All decisions regarding MS treatment and medications should be discussed with your neurologist. And with that, I'll turn it over to Dr. Gross.
Well, thank you, Kelsey, for that wonderful introduction. I'm glad you did include that caveat, a little disclaimer about that, because I was going to say something very similar, which is that, I'm going to try to give kind of broad answers to some of these questions. Some of them, seem to be coming from a person that, who's asking kind of a very particular question, but I'll try to keep it, more kind of broadly relevant to others if I can. And yeah, I guess without further ado, I'll just get started with the questions so we can try to get to as many of them as we can. So question number one, in addition to pelvic floor therapy, is there medication and or anything else to help with neurogenic bowel incontinence in addition to healthy diet? Okay, so yes, this is a great topic, and I'm actually going to put into the chat here a little online brochure that's available through the National MS Society website, which I find to be actually a really helpful primer on this. So bowel symptoms, I think, are actually pretty common, and I think maybe under-recognized in MS. And there's a few different ways things can go. I think the most common thing we tend to see is constipation as a symptom, and that is actually quite common. And constipation, I think there's there's a few different ways that you can deal with it. One, very importantly, is trying to kind of establish a regular routine of going to the bathroom. And making sure that people are making sure you're well hydrated, and that actually, some people will. That's kind of part of the reason that it that problem can be exacerbated is because a person may have trouble with going to the bathroom to urinate frequently as well. And so if they're trying to avoid drinking too much water to prevent that urinary, rushing to the bathroom situation, then they might, actually make their constipation problem worse. And so sometimes when people have constipation problems, that can also lead to trouble with incontinence, of incontinence of stool. In addition, there could be issues with not being able to feel kind of that area down there to know when a person needs to go. And so those things can happen. And generally kind of the first order of business is to try to address, if we can, the stool, making sure that it's not too hard. So if stool softeners are needed, then that's one way to go. Making sure that there's that the person is going regularly, and so if they need to take something like a pro-motility agent, that can be used, something like a Miralax. Occasionally also constipation is treated with suppositories if the oral things are not cutting it. And then in kind of extreme cases, enemas can be useful as well. Diarrhea is kind of a less common problem, and if that happens, especially if it happens kind of abruptly, you want to make sure that you're not dealing with some kind of stomach bug or infection of some sort. You can do things to kind of bulk up the stool, so fiber, Metamucil, things like that can sometimes actually be very helpful in that regard. There is like Lamodal, which is kind of slows down the transit of the stool through the gut. So sometimes if people are having too rapid of kind of from the time food is eaten to the time it passes, then you can kind of slow it down with that kind of thing. Occasionally, we neurologists will refer patients to gastroenterologists for kind of more in-depth evaluations and kind of thing to make sure we're not missing something else, some other condition that could be contributing to that. Yeah, I mean, I think those are kind of the main things, but there's certainly a lot that can be done. So I wouldn't necessarily just say like, oh, this is just happening, there's nothing we can do about it, kind of thing. But check out that link, and there's good actual good facts on there. Question number 2: are there any diet restrictions or applications for MS? So not really sure what applications means here, but as far as what kind of recommendations do I have as far as diet goes? I think diet is a very important aspect of a person's overall health, and I think we should all be trying to eat healthier. I know I should be. But what does that mean exactly? I think depending on who you talk to, you might get slightly different answers, or maybe dramatically different answers. As a general rule, I try to avoid telling people that you should just eat this particular diet that happens to have a name, or what have a person's name even. I think a lot of those diets, especially the ones you find online where people are saying, oh, this is the one that everybody with MS has to be on, I think that there's often not the most evidence to support those claims. And if it were me and somebody was telling me I had to kind of eliminate whole categories of food from my diet because I had MS, so like I couldn't eat bread anymore, I couldn't eat cheese anymore, I couldn't eat meat anymore, like because I enjoy those things, I would probably say, nah, that's kind of not for me. And I think that's there is a little bit of people can decide what makes the most sense for them, because diet is a very important part of living. And so if you tell somebody they can't eat any of the things that they enjoy anymore, then that's kind of like you're eliminating a big part of kind of who they are and what they enjoy. But I think some general rules can be helpful. So things like trying to avoid processed foods, trying not to eat too many packaged things, and lots of fresh foods, veggies can be helpful. trying not to eat like too much, deep fried foods, try to avoid like a lot of desserts all the time, things like that. I think kind of common sense things can be helpful. Sometimes we'll refer folks to dietitians or nutritionists to kind of get more, more in-depth advice on different diets. If somebody, really wanted to know like which particular diet that I would, select for them, I think there's some evidence to suggest like a Mediterranean type diet or a South Beach type diet might be a little bit, more, more healthier for folks with MS. But I think there's probably other diets out there that would also be, equally fine. So yeah, that's kind of my spiel on diets. How necessary is number 3? How necessary is MRI contrast of C-spine or T-spine if a person is SPMS with progression of symptoms, but without a relapse or MRI change in more than 10 years? Okay, well, that's a really good question. So I think the question is just how important is getting the MRI of the spine at all versus, how important is it to get an MRI with contrast of the spine? But I guess I can answer both of them. In reality, we tend not to see a whole lot of change on our MRIs in folks who've had progressive MS for some time. Most of the time, the MRIs are not telling us what's going on, why the person is getting progressively worse. And that's true for, I think, the brain MRI and the spine MRI. We tend to look at the spine probably less often than we look at the brain, although practices do vary in that regard. But overall, I think that it is something that we tend not to see a whole lot of change in terms of new lesions or active lesions, despite people telling us that they're getting worse, which raises a question: well, what's actually driving that process? And I think that's a whole long talk that I'm sure we've given in the past. But as far as progressive MS goes, the short answer is that even though MRIs have become more sophisticated, they are not necessarily showing us what exactly that substrate is for why people are getting progressively worse. We think it probably has to do with kind of you're depleting your kind of natural reserve, your natural neurological reserve. Oh, good. Kelsey has included this helpful comment in the chat that Dr. Corboy will be speaking about progression independent relapse activity on November 4th at the Education Summit. So definitely tune in to that. So my brief kind of comment is that, I think getting an MRI, it's probably worthwhile to do, also because you may be able to catch other things like degenerative spine disease that could potentially be contributing to symptoms. So it might be a good thing to do if it really has been a long time since your last MRI of the spine. If things are getting worse, I think checking to see if there's something actionable, certainly makes sense. And maybe there are other tests, blood tests, or EMGs or other things that can also be done in that setting that might help kind of you figure out. But if it is just MS progression, then we don't really have a great test for that other than what you tell us and what we see on our examination. And so we're working on trying to get better at that, and also on trying to improve our treatment options. But we'll get to that in a minute. Okay, number 4, my current neurologist is retiring. By the way, if you hear dogs barking or children screaming, I apologize. We'll do my best to keep them quiet. Question number 4, my current neurologist is retiring and I will need to transition to a new MS specialist. Do you have any tips and strategies for moving forward with a new practitioner? Thank you for that question. Very good question. And actually, I think Kelsey already mentioned that there's a webinar coming up, I think in the next few days, on how to prepare for a visit with the neurologist. Is that right, Kelsey? Yeah. Okay.
Yeah, we'll put a link in the chat.
Terrific. But I think so. A few kind of basic principles would be, make sure you do have the stuff, with you, any discs, images, files that you've kept from prior neurologists. I can't tell you the number of times that somebody said, oh, they told me they were going to send that stuff. They might have said that, and maybe they intended to, and maybe they did, and maybe it's just, our computer system didn't get it uploaded or what have you. But it's always helpful to have that extra, and especially the discs of your prior MRIs, because oftentimes, even if the neurology office wanted to send those images, they're not necessarily able to. You have to kind of get the disc from the place where the MRI was obtained, the radiology facility or what have you. And so you bring those with you to your visit. And that's kind of the most reliable way that we can make sure that they get uploaded into our system. Also, it's a good idea to come with, some idea of what you want to accomplish in the visit. I think, having 2 or 3 things that you want to make sure you ask, or you want to make sure to get addressed by the end of the visit makes sense. Unfortunately, we don't necessarily have all the time in the world to talk about everything. And so, if somebody comes in with, 15, 20 things that they want to discuss, it's not going to be something that we're going to be able to do in a single setting. So we might have to, have the person come back and maybe have them come back again and again, just to make sure that we, get to all of these things. I've also had patients who, they come for their first visit and we say, I say, what can I do for you? And they say, I don't know. My doctor just told me to come here. So that's not always the most helpful thing either, because then I kind of have to start from scratch and figure out, why did your doctor want you to come here? What is it that I can do for you that, maybe that person wasn't able to, or didn't have the ability to do for you. And so, 2 or 3 things that you want to try to address, maybe particular symptoms, maybe you have a question about the, your prognosis, what things are going to be like for you in the coming years. So those things, and it can be helpful also to write it down, make sure you come there with something written down, because maybe in the moment you won't exactly remember what your questions are, but if you have it written down, then that would be helpful too. But yeah, so if whoever's asking that question, make sure you, and everybody else, make sure you stay tuned for that webinar that's coming up. Okay. Number 5, what is the consensus on the Rocky Mountain MS Center's DISCO MS as introduced in the last 2 years? Have there been any additional study results? At what age do you max out for treatment? Okay, very important topic. I'll try to do it justice. What the question is referring to the discontinuation study, DISCO MS, which was a multi-center randomized controlled trial. Well, it was, hold on, it was randomized, but it was not blinded. So it was half the group was randomized to continue their current disease-modifying therapy. The other half was randomized to discontinue their disease-modifying therapy. And these were folks who were with MS, at least 55 years of age, and generally stable for the previous 5 years, I believe. And so the groups were followed, after the study started, and then at the end of the study, the 2 groups were compared to see what, whether one group had, better outcomes in terms of, were they having more relapses or fewer relapses or what have you. And as it turned out, there were very, very few relapses in either arm, in either the staying on the medication or the discontinuing the medication. By the way, these were all different medications. It wasn't just like one particular MS medication. It was people were on, you name it for their MS. Generally more kind of the older medications as opposed to the very newer ones like the infusions, but it did run the gamut. So there was no statistical difference in terms of relapse rate. There, overall in terms of, I think there was just like a couple, 1 or 2, relapses. But Dr. Corboy has definitely done at least one talk on this subject already, and it should be in our archives. And then in terms of just kind of overall, disability status, people generally seem to be, where they started was where they kind of ended up. There wasn't a particular, pattern in terms of that. Where there was a slight difference was in terms of MRI activity that did seem to favor the people staying on treatment, because a couple people had new spots on their scans on their among the group who discontinued their treatment. And so as a result of that, we couldn't definitively say that stopping treatment was the equivalent of continuing treatment in this population. The study result was kind of inconclusive, but it did give us a lot of information about this concept of, when can we safely stop these disease modifying therapies? Because, we kind of, traditionally have just decided, well, if things are going well, why bother stopping? We'll just continue doing, what we're doing. And that may not be the right move for a lot of people, either because, of cost or convenience or side effects, or I think that the bottom line is we aren't sure that these treatments are actually doing anything, are actually having any kind of particular benefit beyond a certain amount of time. Excuse me. And so that's kind of the background for that particular trial. Hold on, we see something else in the chat. Question, once we get through the list. Oh, okay, it's a new question. All right, so let me just finish this thought here. So so that was kind of the first trial of its kind to really look at that concept of, really just whether you continue the drug or you stop the drug, who's going to do better. There are other trials that are ongoing now to address this topic. And so I think we'll continue to get more information on when it's safe and appropriate to stop. My research interest also includes like looking at trying to develop blood markers to see, is it okay? Can we detect some kind of signal that can predict if somebody is likely to do well or not do well when we stop disease modifying therapy? So, hopefully we'll be able to judge, not just based on, how old the person is, or, how long they've had MS, or when the last time their MS was active, but maybe other factors that might help us predict, how likely somebody is going to do well when they're off treatment. But as it turns out, we make these decisions often in real life. And a lot of people, once they stop their disease modifying therapy, they do all right. They do probably the same as if they had continued it, which again suggests that they probably didn't need to be on that medication. We don't necessarily know for sure until we decide to take that leap. And then, if God forbid something were to happen, they needed to, they had some kind of MS attack or something like that, and the decision is not irreversible, you could always go back on it. So that's kind of the disco, stuff, but we will definitely be hearing more about that. And at what age do we max out? So that study looked at folks age 55 and older, but it probably varies considerably. I mean, if it's different if you're age 55 and you were diagnosed at age 54 versus you're 55 and you're diagnosed at age 20. I mean, those are two very different scenarios. So the person who was diagnosed at age 20, there's a good chance that they're not needing to use that medication anymore, versus the person who was diagnosed at 54 may very well still need to be on medication for the next several years. Okay, number 6. I'm 62 and on Ocrevus. Should I get flu, RSV, and COVID vaccines, and how should I get them vis-a-vis each other and my Ocrevus infusion? Very good question. I'm saying to patients that they should definitely be getting their flu and COVID, their flu vaccine and COVID boosters, provided that there's no specific contraindications, which generally there isn't. And then for the RSV, because this person is over 60, that's actually I have a little thing that I can include in the chat from the CDC on that. It seems like it's generally recommended for folks over 60 who are in higher risk groups, which does include a lot of our patients because they have neurological condition, MS, and or they're on disease modifying therapies that can lower the immunity, and so that might be a good thing to get as well. As far as timing goes, now is generally the answer. It is cold and flu season, and certainly the flu and the vaccine and the COVID boosters are available. I think the question is asking about being on an anti-CD20 or anti-B cell treatment. We do have some indications that the farther you are away from your last infusion, the more kind of robust your response will be to a vaccine, really probably any vaccine. And so the longer you can wait is probably better. That said, like if you're going to try to go for your flu vaccine in March, that's probably too late. So there's a bit of a tension there between, when are the case numbers going to be rising, which is kind of now, and then your immune, and it's not as though you just got your Ocrevus infusion last week. It's not as though you will have no response. You will probably have a response. It just may not be reflected in antibody production, which is not the only way that we become immune to things. By vaccines, are also you're revving up other parts of your immune systems, your T cells and other things, and so it's probably still worth getting, and it's probably something you should get sooner rather than later. Last year, I think I did the COVID in one arm and the flu in the other arm same day, and that was that. Got it out of the way. So definitely encourage people to think about doing that. Has there been any research on liver damage in Tecfidera? I'm not sure about that one. I think it's listed as a potential thing. I mean, it's something we definitely monitor for, but I mean, we're checking metabolic panels on folks who take that medication periodically. But in my experience, that hasn't really been a huge issue with Tecfidera. I think I've had one patient ever have liver issues while on Tecfidera. We see it sometimes with some of our other treatments, I think a little bit more commonly. But certainly if that's something that you're experiencing, as with the disclaimer at the beginning, talk to your doctor and you see if there's another medication out there that would be better for you. But just as a preemptive thing, like somebody recommended that you start Tecfidera and you're worried about liver damage, that's not something that we commonly see. Okay, pain in MS, question number 8. Okay, very important topic. Actually, a topic that I have previously spoken about, I believe, was at the last education summit in the spring. So we should have that archived on the Rocky Mountain MS Center website. But yes, pain does happen in MS. Nerve pain, especially, is very common. And there are lots of treatments available, pills and other interventions that are available. So people don't, you don't need to suffer with pain, and it's not inevitable. I know people used to say, "Oh, MS doesn't cause pain." I don't think that's true at all. I don't know how many people still believe that, but it's definitely something we see pretty commonly. And for the most part, we can improve people's lives with treatment, with various symptomatic treatments. So things like gabapentin, pregabalin, different classes of medications like what are called SNRI, so duloxetine, venlafaxine. Topical agents can sometimes be helpful, like topical anesthetics, lidocaine, for instance. Sometimes people will try different formulations of like marijuana, like CBD. Those things can be either oral or topical, and that's from what I've heard from patients who've tried it, that seems to be helpful in some cases as well. People who have refractory pain, there's other options, including kind of electrical stimulation devices, TENS units, spinal stimulators, in more kind of severe cases that are refractory to other types of treatments. And so yes, definitely talk to your doctor. There's a lot that can be done for pain from MS. And when the pain is coming from something else, obviously wanting to address what that thing is. And sometimes MS can cause pain indirectly. For instance, if it's like more of a spasticity kind of thing that's causing the muscle to be very rigid, and that can lead to pain secondarily, which you would treat with kind of more like a muscle relaxant kind of thing. And I think there is a question also about spasticity coming up as well. Okay, moving on to question number 9. I have a swollen foot and ankle on my MS leg. with bruise-like appearance. Is this common for MS? Yes, I guess that is common. Bruise-like, I think maybe just means like discolored, like kind of bluish. That can happen. I think, it would be important to make sure that, it's certainly, if it's kind of a relatively new thing, you would want to make sure that there's nothing else going on in that leg, like there's no blood clot or anything, maybe an ultrasound of the leg. May also want to have like a good examination of the skin, make sure there's no like wounds or anything like kind of on the heel or anywhere, especially if you're not like moving that leg around a lot. But yes, that's something that we can see when the leg is kind of in this dependent position and the muscles are not squeezing as much to get that blood flow back to the heart. You can have it kind of settle there, and that can lead to the water kind of seeping out and causing some swelling in that limb, and it can look kind of swollen and bluish, and it's generally that leg that's weaker and not moving as much, and so yes, that's certainly something that can be seen. But before we say that that's definitely what it is, sometimes it can be helpful to make sure it's not something more serious than that. And so is there anything to do about that? Well, yes, I mean, you can wear compression stockings. You can do exercises, work with physical therapy to try to, increase the activity of that limb. Things like that can be helpful. Please discuss the latest research with stem cells or other alternative treatments for PPMS. So very good. So PPMS, primary progressive MS, just to take a step back. So one of the main kind of classes of MS that we currently recognize, in which, unlike the vast majority of people when they get diagnosed, it's called relapsing MS or relapsing remitting MS, because a person has kind of a more abrupt onset of symptoms. In primary progressive MS, which is roughly like 10% of the folks who get diagnosed with MS, it's more of an insidious, worsening, insidious decline, usually in terms of kind of walking, not walking as smoothly, not walking as far, kind of dragging the foot or the feet or what have you, more imbalance, gradually kind of worsening over months to years. So historically, that form of MS has been more difficult to treat than the relapsing remitting MS. First drug to be approved to treat primary progressive MS was ocrelizumab, which came out in 2017. Since then, there have been other agents that have been approved to treat secondary progression with activity. In other words, kind of early secondary progression, in which somebody had relapsing disease and then they're a little bit further on, so they're kind of gradually getting worse, but they may still be having relapses, or they're still having activity on their MRIs to suggest ongoing inflammation. A lot of the times, people with primary progressive MS, there isn't that, they're not having relapses necessarily, not having MRI activity, that's kind of the part of MS that our drugs are really best suited to, our current treatments are currently best suited to address. And so that's kind of for that reason that it's been kind of challenging to treat. But like I said, there is Ocrevus, and probably the other B cell blockers may work similarly, although we don't know that for sure. And what new is out there? I mean, I think that's kind of been one of the big things that MS clinicians and researchers have been trying to come up with is something that can slow MS progression down, especially in primary progressive MS. Our center was involved in a trial looking at a supplement, lipoic acid. That trial is wrapping up now, and so we should have some results in the near future about whether that's actually been beneficial or not, in terms of slowing down the progression. I think if you thought about it in terms of kind of three prongs, what you would like to see in terms of MS treatments, you would have the one prong would be immunotherapy. So that's kind of, that's your Ocrevus, that's all the different disease modifying therapies that we currently have. You would have another class of medications that would be kind of not necessarily immune-based, or not immune-based at all, but would maybe have be able to penetrate into the central nervous system directly and then target some of those cells in there to prevent MS progression. So your microglia, your astrocytes, things like that. And maybe lipoic acid will be able to do that. We'll see. There have been other drug trials in recent years that have tried to do that. Ibutolast, the Sprint MS trial from a couple of years back, seemed to suggest that there was some delayed progression and disability. There's other ongoing trials now of non-immune based agents, like there's a statin trial that's ongoing in the UK. That should help us. That should give us some readout in the next couple of years, as far as whether that's going to slow down MS progression. So you've got those two prongs, and then of course the third prong would be some kind of remyelinating or repair agent. And so at the moment we really have immune-based treatments. We don't have any of those other two, but hopefully in the next few years we'll start to get some of those other treatments, and then we can really maybe start to talk about the C word, cure. But I think as far as what we have currently, it's clearly not enough for addressing some of these other aspects of MS. So can I have MS without lesions showing on my brain? I have 90% of the symptoms that I found online. Okay, good question. Well, so symptoms of MS are non-specific. There's a lot of things that can be, say fatigue or numbness, tingling, cognitive impairment, things like that can be seen in MS, that can also be seen in lots of other conditions. And so just having the symptoms doesn't necessarily narrow it down all that much, unfortunately. So we do, especially in recent years, we do rely a lot on MRIs to try to help kind of corroborate when we think a person might have MS. Now, there is no one perfect test for MS, even MRIs. But so that, we as neurologists kind of have to, take what you're telling us, what we see when we do our examination, and then all the other bits of information like the MRIs, and then sometimes blood and spinal fluid tests and other tests. And then we kind of put it into a coherent picture of, okay, is this all telling us the same story? Does this person seem to have MS? And it doesn't help that the features of MS are variable between people. That some people are clearly way more affected than other people, and so that can make the diagnosis a bit challenging. And I can say that it's almost impossible to have MS without lesions on the brain. I can imagine scenarios where maybe the MRI that was obtained wasn't particularly good, or maybe there were lesions there and the person, whoever was interpreting it just didn't see them. That could also be a thing. If somebody has lesions in their central nervous system that are limited to their spinal cord and really none in the brain, it really does raise it really does increase the risk that this is something that's non-MS, but maybe in the autoimmune space, something like a neuromyelitis optica spectrum disorder, so NMOSD, or MOGAD, myelin oligodendrocyte glycoprotein associated disease. So these are kind of acronyms to describe more recently kind of discovered entities that are similar to MS but distinct, that have their own kind of why they come about, and we're learning more about those diseases and their treatments and so forth. But if a person has what look to be inflammatory lesions in just their spine and not in their brain, I suppose yes, it could be MS, but it could also be one of those other other conditions. And so really kind of astute neurologists will have to try to dissect that out and figure out, and that'll probably involve doing, all the tests I mentioned, MRIs of the brain and spine, spinal fluid analysis, blood tests, maybe other tests as well. Oh, good. Looks like Dr. Bennett will be discussing the differences between NMOSD and multiple sclerosis at the upcoming Ed Summit on November 4th. So thank you for that, Kelsey. Okay, good. Next, update on work being done at Anschutz Medical Center on DNA modifications. Would this help those who have had MS for years? I can't say I know what that is. Maybe whoever asked that question can provide a little bit more specifics. Then I maybe would understand what they're talking about, but I actually don't know what that is. So okay. Next, should a person with MS exercise? Yes, absolutely. A person with MS should exercise. It's actually, we recommend it for most of our patients. Getting regular physical activity is good for brain health, good for nervous system health, good for overall health. We usually suggest some combination of kind of aerobic activity where you get your heart pumping, maybe a little bit of resistance to make sure the muscles stay toned, and then especially for folks that need it, kind of train, balance training, and sometimes some of these exercises, you work with a physical therapist, try to develop a program for yourself, and then when that period is over, you kind of hopefully will continue to do those exercises when you're at home. But yeah, even without a physical therapist, doing regular physical activity is definitely encouraged. And beyond that, we already talked about a healthy diet, avoiding cigarettes, because cigarettes are really bad for your overall health, really bad for your MS. And paying attention to your mental health too. I feel like a lot of times we neglect that, and we don't do enough kind of self-care, and so that can be just as important as the physical health. And so making sure that we're paying attention to those things too is important. Number 14, is there any medicine other than baclofen or Xanaflex for extreme spasticity? At what age do symptoms subside? Okay, so baclofen and Xanaflex or tizanidine are two medications that we'll commonly use as muscle relaxants. They're oral antispasmodic agents. There's a bunch of different ones out there. Those aren't the only ones. There's also a methocarbamol, there's cyclobenzaprine, there's a bunch of them, and they kind of all operate similarly. The question asks about something that works in extreme spasticity, and often the oral medications, there's only they only get you so far if the person's spasticity is very bad, and so beyond that, sometimes we will recommend people go to our colleagues. Usually it's a neurologist trained in movement disorders, or somebody who's a physiatrist, to do Botox injections. So Botox, or botulinum toxin, is a basically a paralytic agent that is used cosmetically, for the face to try to prevent wrinkles, but also it's used in muscles to relax them when people have a severe spasticity. And so they'll go for an evaluation, and then they'll kind of target the specific muscles, and they'll inject the Botox in them, and then it'll be kind of on a regular basis, usually every few months, that a person needs to come back for repeat treatment of the Botox. So that's one pathway. Another pathway is you can get baclofen, but delivered directly into the spine, what's so-called intrathecally, through a baclofen pump. So baclofen pumps have been around for a while. You basically have this kind of hockey puck thing filled with baclofen implanted into your abdomen. And then there's a catheter that kind of threads its way into the spine. This is a surgery that needs to be done by a neurosurgeon. And then the pump is programmed, and it can deliver a certain amount of baclofen. It's usually far less than the amount that goes in through the mouth, but because it goes directly into the spine, it has a more direct effect, and you're able to get away with a lot lower dose, and it tends to have a lot less in the way of kind of, unwanted side effects that you can get at higher doses of the orals. So that's another option for folks. People then, you would need to kind of come back periodically to have the pump interrogated, or to have it like reprogrammed and refilled with additional baclofen. Depends on how big the reservoir is, and how quickly you're getting it, what the rate is. But that can be anywhere from a few weeks to a few months, where you would need to kind of come back. And there are also companies that can go to people's houses now and do the refill. And so that's another option for folks who have extreme spasticity. So our options are, they're limited, but there are some options available. And so yeah, let's move on to the next question. Does Ocrevus lose its effectiveness after a few years? So no, not exactly. I was kind of alluding to this before. There's no point at which it stops doing what it's intended to do, which is Ocrevus or ocrelizumab depletes a person's B cells, and in so doing, people with MS tend to experience far fewer relapses and far fewer MRI changes, and that's kind of what Ocrevus is intended to do. That's what it's been shown to do, and that's what it does. But over time, a person's MS changes such that they're not necessarily having relapses, or they're not necessarily having new inflammatory events on their MRIs. And so Ocrevus or any other disease modifying therapy may be less needed. And that's kind of the basis for why we wanted to look at this in the DISCO MS trial, for instance, is that it's not that the drug isn't working, it's still working. It's just it's not it may no longer be necessary, and that's tricky too, because we tend to see more progression, that kind of insidious progression over time that I was describing before. We tend to see that more as people get older, but that part of the MS tends to be less responsive to Ocrevus or any of our other treatments. And so even if we were to stop a person's Ocrevus, that may not change the overall trajectory. And so that's, again, something we're still working on, trying to learn more about, and of course to discover new treatments that may be effective in that setting. And so yeah, let's see, number 16. I would like to know more about findings on cognition/mental health aspects of MS. Okay, good. Yeah, that's a very big topic. Cognitive problems are very common in MS. So some things that we tend to see a lot are short-term memory loss, trouble with concentration, slowed processing. So yeah, those things tend to be pretty common. I mean, it's relatively rare for people to be, really advanced with cognitive impairment. So it's not known as a dementing illness the same way Alzheimer's disease is, for instance. But I would say certainly mild difficulties with cognition are pretty common in MS, and again, maybe like bowel stuff, maybe even under recognized. Although I think in recent years people are recognizing it more and more, and we're talking about it more and more. Neuropsychological evaluations. These are usually a few hours and kind of a comprehensive battery of cognitive tests. We often will refer folks for that. to kind of get a more granular sense of, where you're struggling, where you are compared to kind of your, age matched cohort. And certainly if it had been done previously, like you'd had a neuropsych evaluation 5 years ago, then, and we have the records of that, then we'll be able to compare and see, has there been any decline, or are you pretty much where you were before, in terms of those, of all the different areas that can be affected with MS. And then sometimes it can also be helpful to, if we're kind of trying to figure out, is this MS, or could there be something else going on? I've had patients with MS I've also diagnosed with Alzheimer's disease. Not that one causes the other, but just because, of random bad luck. Certainly something like Alzheimer's disease is very common, especially as people get older. And so just statistically, we're going to have some people who have both things. And so and that might, you might be able to determine, for instance, using a neuropsychological assessment, whether this pattern of cognitive involvement is kind of like maybe more or different than what you would expect, than just pure MS alone. So it can be helpful diagnostically in that sense as well. And so let me go back to the question here. So yeah, the question asked about cognition and mental health aspects. So mental health, also is important. So I mentioned, earlier, I think things like, depression, anxiety, incredibly common, well, in the general population, but, even more so in folks who have MS. And so, we want to make sure that people are getting, appropriate treatment for those things. And sometimes it's through us, your neurology team, and sometimes it's through dedicated, mental health experts, or some combination thereof. And it can involve, therapy, talk therapy. It can involve medications. Sometimes those medications will be similar to medications that we might prescribe for other things like nerve pain. I mentioned venlafaxine and duloxetine earlier when I was talking about nerve pain. Those are also antidepressants. And so if we can, kill two birds with one stone, that can sometimes be a good thing, because a person might have some, low mood, and they might also have nerve pain. And so you use that medication or one of those medications, and you might be able to get some benefit in both of those areas. And so yeah, both the mental health kind of, mood disorders, that kind of thing, very common. And then cognitive, memory stuff, processing things, also very common. And, to a certain extent treatable. I mean, if depends on what's kind of driving it. If a person is feeling like, less energy, just kind of down, not getting out of bed, and they're just kind of cognitively slowed in that setting, then, maybe addressing their mood, maybe even treating with like a stimulant for the energy, maybe that can give them a boost in terms of their mental, processing as well. There's not like one great medication to improve memory in MS, or as far as I'm concerned, in other neurological disorders either. But we will sometimes use, off-label medications that have been approved to treat other illnesses like Alzheimer's disease. We will sometimes use that to treat folks with MS who have cognitive impairment, and so I can't say I've seen amazing results from it, but that'll be some. Sometimes we'll use those type of medications. Yeah, but it is an area that, again, we would like to have better options, things that can really target the specific mechanisms of cognitive impairment in MS. And so hopefully we'll see some of those in the near future. Number 17. What is your opinion for staying with a preferred drug, and then in parentheses Ocrevus, after having 9 doses uneventfully, and on the 10th, the nurses suggested the drip be faster, and in parentheses 2 hours, an allergic reaction began. The throat began to close, and they had breathing problems. Benadryl was given, drips will slow down, and the treatment continued. 3 months later, patient had has continued problems with the reaction, with difficulty swallowing and feel like on the verge of choking. GERD or reflux is now an issue too. Recently started medication for that. Never had issues with it before. Another infusion is due in 3 months. Is it safe to take at the regular rate or even slower if possible? Okay, that's kind of tough to say. So, Ocrevus, we can see some infusion reactions. Most commonly, those are with the first infusion, really, like the first 1 or 2 infusions. The rate of infusion reaction, the incidence of infusion reactions is a lot less by infusion number 3, and then like 4 or 5, like it stays very, very low. And so, it is far less common for people to be fine for 9 doses, and then on the 10th dose have the issue. But the person here, the question says that it was or really implies that it was because that on that dose it was the faster rate that led to the problem. And we can see that for sure, that when instead of doing it at the standard protocol, recently we've started, which generally takes about 3 or 4 hours. Recently we started doing it at a faster rate for some people who've tolerated it well in the past, and that usually goes over about 2 hours. But as you're ramping up that rate of infusion, you can sometimes start to get that some kind of an allergic type reaction, maybe some itching, or some, in this case, that throat began to close instead of breathing problems, which can be scary. And so usually the response is to slow it down or to shut it down, give some additional pre-medication like Benadryl, and then to resume it at a slower rate. What's kind of peculiar here is that they say that the reaction has persisted. Now, I'm not entirely sure what is driving that. So it says it's now reflux or GERD that has become an issue that wasn't an issue before. I mean, I don't really see how that is connection, except based on the timing of what they've described here. And so I'm not sure how that entirely plays in. So they're asking, will it be safe to take the Ocrevus again at a regular rate? I mean, they tolerated it well before at the regular rate, so probably, or even slower. Yes, probably. I mean, I don't see why not. It doesn't sound like it's anything that's necessarily serious. Again, discuss it with your neurologist. Sometimes we'll use pre-medications even before the actual day of infusion, so the days leading up to the infusion. I might recommend somebody to take like a Zyrtec or a Claritin, an oral antihistamine, in the like 3 or 4 days leading up to their next infusion, and that can help reduce the risk of that kind of allergic type reaction, in addition to whatever medication that you're going to be getting, which is usually Tylenol, Benadryl, and IV steroid at the time of the infusion. So I would say, yes, probably, but talk to your neurologist and, have them, kind of suss out your concerns. And if, there are certainly other options that are available to you, if you don't want to go that route. Okay. Number 18, when an MS patient is given a steroid dose pack for an unrelated illness such as shingles, is it okay for the patient to take it when they have had negative reactions to high-dose steroids in the past, for example, psychosis? Good question. Yeah, so obviously steroids are given for a variety of different purposes. Most of the time for, some of these other conditions, they're not necessarily using the high-dose steroids that we tend to give when people have MS relapses. So for example, like we're usually using a methylprednisolone, the IV formulation, 1,000 milligrams a day, which translates to about 1,250 milligrams of prednisone per day. And actually, in recent times, we have, in many cases, given the 1,250 of prednisone by mouth, so a person can, be treated for an MS relapse at home instead of having to come to the hospital, which has been more convenient. But for a lot of other conditions, you end up seeing far lower doses of steroids than what we use in MS. And of course, steroids can have, lots of different side effects. This person mentions one, the psychosis, which can happen rarely. But lots of people will say that it makes it difficult to sleep, that it kind of revs them up, makes them feel jittery. It can certainly affect other things like, can raise the blood sugar. It can, can cause kind of water retention. With prolonged use, it can, increase susceptibility to infection. It can, cause bone loss, all sorts of, things. So, in general, I try to avoid steroids when I can, for those reasons. But sometimes they're necessary. Sometimes they're necessary to treat other things, and then the person, the provider who's prescribing it, just want to make sure they're doing it wisely and judiciously, and not more than is necessary. In this particular case, it's kind of hard to say. A low dose of oral prednisone could be fine, or oral steroid could be fine, or it could could have a problem. So I'm not sure what I would do. Maybe I would talk to the prescribing doctor and just see, like, if that's, how necessary is it, or are there any other alternatives? I don't know that I would say it would be an absolute contraindication. But yeah, I mean, that's kind of probably how I would approach that particular scenario. Like, if it seems like it is, like there are other things where it's like, no, this is the actual treatment for this condition, then I would say, okay, yeah, then yeah, go for it, but just, be very careful, kind of thing. Number 19, what really helps cognition / brain health? Already exercise, eat healthy, qigong, sleep, yoga, meditate. Anything else that I can see a major improvement? Oh boy. Yeah, I wish there were. I wish I discovered it so I can, become a billionaire. Yeah, because I was kind of, already discussing this before. I think for cognition, there's not like great medication out there. But you have mentioned a lot of things that we will frequently suggest. So in that sense, you're already ahead of the curve. So, regular exercise, eating healthy, mindfulness, or some of these other activities like meditation, yoga, are also good. Sleep, that's also very important, which I didn't mention before, but thank you for bringing it up. Sleep is a very important thing, and that's actually one thing that probably is strongly linked to, developing dementia in the future. So people who don't get good sleep, they don't allow their brains to reset. They're probably preventing the clearance of some of this, toxic debris that can lead to things like Alzheimer's disease and other things. So sleep is actually, super important. And I think there's an epidemic of poor sleep in this country, especially, that people don't value it enough, or get good high quality sleep. So, you probably should be sleeping like 7-8 hours a night. And if all goes well, you should wake up and you should feel refreshed. And if that's not happening, then we really need to investigate why that's not happening. And if it's some your behavior that's doing it, because you're not setting a routine and not following through on it, or you're having bad, negative behaviors, watching too much TV right before sleep, or other things, then those are things that you can work on. But if it's some kind of medical issue, if it's sleep apnea, which is very, very common, even especially in folks with MS, if it's some other kind of sleep disorder, those kind of things can be sussed out with, sometimes with a sleep study. But you'll talk to your neurologist, and they may make referrals, or they may order certain tests to see, what else is going on, and if it's correctable, because we do want you to get good sleep and wake up feeling refreshed. And that's that's super important for so many elements of your day-to-day living, your energy level, your cognition, just all of it relies on a good base of sleep. But yeah, I know, as far as anything else that really helps cognition, brain health, those you mentioned the main one. So if everybody could do all of those things, the regular exercise, healthy eating, mindfulness, paying attention to mental health stuff, then I think we would probably see a lot less issues with brain health. Yeah. So number 20, can MS be the cause of eyelid twitching? Good question. I would say usually not. I don't tend to see a lot of eyelid twitching related to MS per se. So people can have what's called blepharospasm, which is kind of this involuntary, twitching of the eyes or forced closure of the eyes, usually both eyes. But that's probably unrelated. Um, and it could be, there may be genetic component to it, or it could be brought out by certain things like stress or poor sleep or some such things. And sometimes if it's bad, there are treatments that can be used, including kind of injections that might actually help with that, like Botox. But it depends on what's really driving it, and if it's something that's if it's like just kind of a temporary thing, or if it's more a persistent problem or whatnot. But yeah, I mean, I need to see it, and then perhaps I could make a better diagnosis as to what's going on. So yeah, probably not the MS per se. Any support for caregivers to manage depression and anxiety for their spouse with MS and the struggles of everyday life? Okay, yes, very good question. So I think we don't talk about this enough. This idea that it's not just the person with MS that's kind of struggling, but it can be the person who cares for that person. Especially if the patient is more kind of at a more advanced stage, and then the caregiver has a lot more responsibilities as far as kind of making sure they get dressed and fed, and not injured, and all of those other things, and they can never really turn off, and that can be a really huge cause for burnout, which is a real thing. And so yeah, absolutely. There are support services out there. We can usually direct you to them. I don't know if Kelsey, I don't know if you have any particular ones that from like the website or anything, like, but social work can often be useful to kind of help identify caregiver resources. There are different agencies out there that like elder agency type things where you can find support, and yeah, so I think the first thing is just to make sure that you talk to somebody, you talk to the doctor about it or whatever, and then they can try to get you some helps. And oftentimes there are things that can be done, if only just to kind of have a sounding board to kind of have your discuss what you're going through. But even beyond that, you could potentially have other support services in place that can actually help take some of the burden away, to kind of do some of the stuff that you're doing, so you don't have to do it. So next question, number 22, new therapy options for MS. So yes, so there's the field is always evolving, and we're constantly getting new drugs, testing new drugs. As I kind of said before, the drugs that we have, the landscape that we have so far, even though we have dozens of medications to treat MS that modify the course of the disease, they're in this kind of category of immune-based treatments or immunotherapies. And so in that sense, they're acting on the same general aspect of the MS. And so yeah, going from like the old stuff, the injectable agents, the Avonex and beta-seron Rebif, the interferon type products, the Copaxone, the glutiramer acetate, those type things. So those have been around for a long time. They'll continue to be around. The new thing there, I think, is that we may get a monthly depot in the first quarter of next year for glutiramer acetate. So just like a once a month type shot. That's when we get to know whether the FDA is approving it or not. And so that'll be interesting. As far as the oral medications go, we've got a number of different classes represented now. We've got the Aubagio teriflunomide that's been around for a while, since like 2012. We've got several different fumarate options available. So the earliest was the Tecfidera dimethyl fumarate. Now there's monomethyl fumarate or Vafirtam. There's diroximel fumarate, which is Vumerity. And so we'll use all of these, kind of interchangeably. There's the S1P receptor class. That's the original one was Gilenya or fingolimod. There's now biosimilar fingolimod. There's also several other mods out there that are in the same class, siponimod or Mayzent, ponesimod or Ponvory, ozanimod or Zeposia. So these all act on that S1P receptor and are once a day pills. More alike than they are different in a sense in the way that they probably work on the MS. And then we have got the infusible medicines, kind of oldest one we don't really use anymore, like mitoxantrone, alemtuzumab or Lemtrada is still around. Kind of carries a lot of potential side effects, and so it tends to be reserved for more severe cases, at least in our practice. There's natalizumab or Tysabri, which also has a biosimilar available. And then there's the anti-CD20 therapies. So like Ocrevus, which is the one that we've discussed already, was approved in 2017. More recently, ublituximab, which is also anti-B cell therapy, has been approved in that class. And then also we've got Kesimpta, which is a B cell blocker, but not an infusion. It's a self injection. So different classes, lots of different medications, but far fewer just in terms of number of classes that are. Oh, and I didn't mention cladribine as well as another oral medication in the class of its own. And so we'll use one or another. Depends on the circumstance. There's not like one particular factor. You have to kind of take the whole picture. What the person has tried before. Sometimes the results of certain blood tests can help inform whether we're going to go with one or another. And so there's a lot of different options out there, thankfully. And again, they're all kind of in that immune-based category, and so hopefully we can get those. We can continue to use those and also develop others that may be more neuroprotective or reparative in other ways. So what is the latest research on the Epstein Bar virus? Okay, great question. And I see we have about 15 minutes left or so we should be able to get through most of these. So the Epstein Bar virus is, well, we've kind of known for a while that it's been associated with MS susceptibility. And in the past year or two, we've gotten even more evidence of that connection. There was a really elegant study that looked at military records. So young people who entered the military, and they had their blood drawn when they came in, and then periodically over the course of their time in the military, and they were able to see who ended up developing MS, which were a few hundred people out of however many millions that the records looked at. And they looked for exposure to different viruses, upon entry, and then over time. And what they found was that people who, when they entered, if they had not yet been exposed to this Epstein-Barr virus, and then they became exposed during that time, then they were, far more likely to develop MS than other people. It was a very high, I forget what the exact number was, like a 30-fold increased risk. And that was also far more than any of the other viruses they looked at, like not even close. In fact, everybody who subsequently developed MS, I think except one person, was exposed to the Epstein-Barr virus in that time period, as was demonstrated by their blood work that showed antibodies to the virus. And so it really kind of solidified that particular pathogen seems to have a crucial role in the development of MS in people who are probably inherently predisposed to getting it. And so, working theory is that it's probably those folks, maybe they have, because of genetics or whatever other risk factor, when they get exposed to the Epstein Bar virus, their body or their immune system is not really able to kind of deal with it the way others deal with it. Because in fact, it's a very common virus, and almost all of us, by the time we reach adulthood, have been exposed to that virus. But we somehow manage to kind of calm it down or make it such that it doesn't create a problem, whereas people who develop MS, they can't control it effectively, and so then that leads to the immune system kind of getting tricked, and instead of going after a virus, as in this case, it decides that it's going to attack your myelin, your central nervous system. And so that's what happens, and that's what leads to people getting MS, we think. So yeah, it does seem to be probably the trigger for MS, which is something that is interesting to know. I mean, I think it's that's kind of academically like, okay, yeah, but we haven't really been able to do anything about that because we haven't really had effective vaccines against it. Now there are several companies that are working on it, including I think Moderna, which did one of the mRNA vaccines for COVID. And so we may actually end up seeing effective vaccines coming out for the Epstein Barr virus, and then the question becomes like, if we can prevent people from getting a primary Epstein Barr infection, will that prevent MS from happening? And I think that the answer to that question is going to be a few years away. They have to develop these vaccines and then test them out on large populations of people to see whether it actually does prevent people from getting MS. But I think that's I can envision that happening. That's actually not going to be, that'll probably be not too far. I can't tell you exactly how long, but 10, 15 years, whatever, that we might actually start to see, evidence of that. So we'll see. Let's see. I guess, Kelsey, should I go with the questions from the audience now, or should I keep going on the list?
Let's go ahead and answer both the question from the audience and then the one that was earlier, which I can
yeah, okay. The one from earlier I see was, once we get, okay, what question as an individual newly diagnosed with MS should you be asking? As newbie, things that come to mind are, why or what do I do now? But there are more specifics that will aid in transition of this journey. Yeah. So when I have a patient who's newly diagnosed and in my office, I'll often walk them through the diagnosis, explain how I came to that conclusion. And then, we'll usually talk about treatments, because I think going on a treatment, especially for a newly diagnosed patient, is like kind of the most important thing that we can do. And then we talk about a lot of these things that, we've discussed today, kind of, what causes MS, are there things that you can do, diet, exercise, things like that, avoiding things like cigarettes, that kind of thing. People often ask me about like marijuana or alcohol use, which, I think both of those, alcohol probably fine in moderation, marijuana, like, we need to know more about it before we can say, even though it's been around forever. We haven't really done kind of rigorous clinical trials on it, but I've certainly had a lot of patients who've, taken it and said that it might help with this, that, or the other. But yeah, I mean, we go over all of that stuff. We talk about kind of, if they are wanting to have kids, what that might look like. We actually, one of my colleagues, Dr. Shaw, has a particular interest in what happens to women with MS who want to get pregnant and want to breastfeed, and how that should play out. But it is definitely very doable, that kind of thing. And so we might go into family planning a little bit that first meeting. Sometimes this takes multiple settings to really get at all the questions, as you can see, because it takes a long time to really do justice to a lot of these questions. But yeah, and then as far as kind of things that I can help a person to, like, understand what's going to come, or that kind of thing, it's I don't have a crystal ball. I can't necessarily tell you the first time I meet you, what things are going to look like when 20 years from now, 30 years from now. But, especially with, people who are newly diagnosed, relapsing, remitting, and we're getting them started on treatment pretty quickly, future usually looks pretty bright, and we're usually able to get people, their disease settled and stabilized. And in fact, some people do experience improvement in their symptoms compared to where they were before they started treatment. And so, often I just kind of say, like, look, I think things are probably going to go really well for you. But we'll just have to, you keep coming back, and we keep an eye on things, and hopefully you continue your medication. Doesn't have to be necessarily the same medication that we talked about the first time, but it could be a different one or whatever. But like, as long as, that we have this relationship, and, you keep coming back, and we can hopefully keep the disease under control. And that you should be able to continue to do the things that you enjoy doing, and hopefully for as long as you want to keep doing them. That's kind of what I tell people, what I hope for them. And so yeah. Next question. Is GERD something you see as a side effect for your patients on Ocrevus or other infusions? It's not listed as one, but I experienced it strongly right after my infusions, and a previous question mentioned as well. Yeah, it's a good question. I mean, I've heard it before, but I do wonder whether it might be related to maybe like the steroid, for instance, that a person is getting, like that maybe that's what's causing the GERD. I mean, it certainly could be the Ocrevus, but I wouldn't expect it to like persist for like months and months, because the Ocrevus will have been out of your system by then. And so yeah, so I guess I'm not sure on that one. It's not a common one. And if it's anything that's treatment related, I would expect it to be short-lived. I wouldn't expect it to persist and persist and persist. Because if that's the case, then it may just be that you have that thing. Maybe it was unmasked by the Ocrevus, but I mean, GERD is something that we can, treat with medication and behavioral modification and things like that. So yeah, I mean, the one way of finding out would be if you were to switch to some other medication and then it went away. I mean, it wouldn't be the most scientific way of doing it, but I mean, that'd be one way of trying to figure out if it's truly related. But yeah, I would say, if it's something that's tolerable, and there are ways of kind of reducing it or mitigating it, then maybe just stick with the Ocrevus. But yeah, it's a personal decision. That's something you have to work out with your neurologist. Okay, quickly for the next ones. I'm discontinuing Gilenya due to insurance. In January 2024, I've been told I should consider beginning Ocrevus, because discontinuing Gilenya, basically it could cause a relapse if you stop it abruptly. Ocrevus would fall into Medicare Part B billing, would be significant savings for me. Is this the right thing to do, or is there another drug should I consider? I reached needle fatigue years ago on Avonex and then Copaxone, so needle injection is not an option. Your thoughts? So yeah, I mean, I mentioned there's a bunch of different medication options out there, including other orals. I mean, we do use a lot of Ocrevus, and it sounds like it would be, cost saving for you. So yeah, I mean, I think that would be a reasonable option, especially if you're not going to consider another injectable. But maybe you want to talk also with your doctor about. So I guess I'm not entirely clear. Was the idea that it would be just like a one and done kind of thing, like you would do Ocrevus like one time just so you would avoid the Gilenya, rebound that could happen with Gilenya discontinuation, and then kind of stop? Or would it be just Ocrevus, ongoing after that? I mean, I think you could consider either one, but given that it sounds like maybe you've had MS for a long time and you've been on lots of different disease modifying therapies, how much longer do you might want to ask, how much longer do you actually really need to be on a disease modifying therapy at this point? So yeah. So that's something to think about. Update on research. Okay, that's a little broad. I don't know if I can necessarily come up with anything at the moment. Okay, number 26. Although I have been diagnosed with MS, I'm not currently experiencing symptoms. Is there specific exercise regimens, activities, or diet I should be following? I think we kind of already addressed that. That's good that you're not experiencing symptoms. I definitely don't want you to become hypervigilant or start to think that any little thing might be the MS. It may just be your MS has been quieted down. I wonder if that's because you started a treatment. Are there specific regimens? Yeah, I mean, no, regular physical activity, like I said, healthy diet. I think those are just good, sound advice for everybody. And then, hopefully you have a good relationship with your neurologist and you're following up, on a periodic basis to just check in and make sure, and then maybe getting an MRI every once in a while, kind of thing. Next, do you think symptoms lessen with age? I kind of talked about the changes that happen with age. So relapses become less common, abrupt changes tend to become less common, but progression or insidious worsening may become more common depending on the person. And so I wouldn't necessarily say that symptoms lessen with age, but a lot of folks that I follow, they're just kind of holding steady, and they're not necessarily getting better or getting worse with age. They're just kind of, they've got their symptoms and they're just living with them. And so yeah, it depends on the person, but a lot of people, they just kind of plateau kind of thing. If there are not any other pressing questions, I'd like to know if there's any new research into PML. Seems to have stalled. Okay, PML, progressive multifocal leukoencephalopathy. It's an opportunistic infection. It's caused by the JC virus, the John Cunningham virus. We've known about this for some time. It's actually a pretty ubiquitous virus. More than half of us have been exposed to it at some point and might carry antibodies to it. Several of our drugs have been linked to the development of this infection, which is kind of a nasty infection in the brain. But the biggest relationship is clearly with natalizumab or Tysabri, where there have been several hundred cases. With some of our other medications, with Tecfidera, with Gilenya, there have been several cases. With Ocrevus, I believe there's been 2 confirmed cases out of several hundred thousand. So the short answer is anytime you tweak somebody's immune system, it always potentially increases the susceptibility to infection. But there is clearly some medications that are far more like Tysabri that are do it much more than anything else. And so, for me, a general rule, I don't even necessarily think about it if I'm starting somebody on Ocrevus or a B cell blocking agent, because I think the odds that somebody's going to get PML from that is exceptionally low, and it'd probably be higher with almost any other medication, even though it wouldn't necessarily be particularly high. Like with Tecfidera, it's like 1 in 50,000 or something like that. And so if the question is about PML treatment, I think that's another. So it can be devastating. It can be fatal. About a quarter of the time it is in modern day. There's not great treatments out there. There are a couple of clinical trials, I think, that are including one that's looking at recombinant IL-7 protein, which is it's like a chemical messenger that's trying to boost the immune signal in folks with PML, and then another one which is trying to introduce T cells that have been manipulated. So I think those are very experimental. We don't have great treatment options, but it's supportive care. And if it's caught early, perhaps people can do better than if it goes on longer. So we would very much prefer to avoid it if we can. And so, yeah, that's kind of where the research is at. Now, I think there's one more question in the chat. Maybe I can get that. What progress has been made on remyelination drugs that will take all my MS symptoms away? I thought we were going to get through them all in time. I got to speak really fast. Again, remyelination drug, still don't have anything. There's been some cool studies recently, looking at potential remyelinating therapies. One that I saw at a conference in April was looking at this gold nanoparticle suspension. That seemed pretty cool. They did a small study that looked at people who had prior optic neuritis and giving them that suspension versus people, I think they were given placebo, and they actually found it did show some benefit, some improvement in their vision. But it was a small study and be something nice that we could, hopefully replicate with a larger trial that would involve, lots of different centers and different kinds of patients. And so I think, hopefully, if they do design such a trial, I mean, I think our center would be happy to participate. And we're always, on the lookout for good ideas, things that sound like they could work. And hopefully, there's funding for for that trial that, would help, make it run. And so yeah, if you guys have any good ideas, bring it to our attention. And so thank you all for your participation. I really, really appreciate it. I really enjoy these sessions. Yeah, you should be able to see this. It's recorded for posterity. And so yeah, thank you. Take care.